We're going to move on in this unit and talk about the normal presentation of postpartum and as well as postpartum complications. This is Unit 5 in your textbook, so it's going to encompass chapters 20, 21, 22, 23, and as well as chapter 26, where we will discuss infant feedings. So when you look at Objective 89, comparing the basic physiologic and psychologic changes that occur in the postpartum period, the thing you need to remember is the pre-partum period is the 6 weeks that follow childbirth, and that is the time that normal involution occurs. And when we're talking about involution, that's referring to the uterus returning to its pre-pregnancy state. The organs inside of the maternal abdomen, thorax, they will return to pre-pregnant state. And this can also be considered the fourth trimester of pregnancy. So when we're talking about the uterus and we're talking about involution, what we like to see is that the uterus is decreasing by 1 to 2 centimeters every 24 hours until it is back in the low pelvis. When we are looking at involution or trying to assess involution, that's where you're going to be doing your fundal checks, and that is going to be the importance behind fundal checks, because we want to ensure the uterus is going through the normal involution process. If subinvolution occurs, that is a failure of the uterus to return to that non-pregnant state. And typically what we see happening is that oftentimes women are discharged from the hospital and they continue to have bleeding, and really the most common causes are retained placental fragments, or it could be an infection. So subinvolution may be occurring normally in the hospital, but then once mom is discharged home, we can see subinvolution occurring at home, and then when she comes back for her 6-week postpartum visit, oftentimes that's when it is documented. So when we talk about documentation of the fundus, what you would like to note is that the fundus should be firm and not boggy. It should typically be midline of the abdomen, and then immediately after the delivery, it should be at the level of the umbilicus. So when you are looking at this picture, you can see that she is using one hand to support the lower segment of the uterus, and then her other one is going to roll down and then massage the top of the uterus, otherwise known as the fundus. If the fundus is boggy, then the priority nursing action is to massage it until firm. When you are doing fundal massages on maybe fluffier women, you may have to push and palpate a little deeper in order to palpate the fundus. But if you are not able to palpate a fundus, you do need to go and have someone recheck for you, or continue palpating until you locate the fundus or until that fundus firms back up. So when you are using documentation, these are really the ACOG standards. This is what you are going to be seeing when you are looking in nurses' notes. So FF is that the fundus is firm. If you have to massage it, then you will include that in documentation as well. Or if a fundus is boggy, you will put FB, and then you need to continue to massage it as said until firm. We record fundal height in finger breadths or finger widths below or above the umbilicus. So there's examples listed out up here. If it's 1/U, that would mean that it is 1 finger breadth above the umbilicus. So if the number is on top of the U, that also means above. And if the number falls behind the U, that means below. And so you could anticipate with a U/2, you would see that that is 2 finger breadths or finger widths below the umbilicus. Displacement can occur for a couple of reasons. We could see displacement with retained placenta, but you can also see displacement if the patient has a full bladder. So it's a really good idea with those fundal checks prior to doing those to get your patient up, have her use the restroom, have her knees slightly flexed, support this lower uterine segment as you're seeing in this picture, and then palpate gently until the fundus is felt. Obviously what you're going, your patient is going to have increased complaints of discomfort if she has a C-section, because when you're supporting this lower segment with one of your hands, you probably will have that right on top of that incision. So we do want to use caution, but it is very, very important to assess that and assess that we are having evolution. So again, here's just a pictorial view of what you could expect when you are palpating the fundus. Again, here's another picture that down here we're using our lower hand to support that lower uterine segment, and then 2 finger widths below. You can see her umbilicus sits right here, and then there's 2 finger widths below that. If a woman does have a full bladder, again, just have her use the restroom. After pains are really reflective of kind of like uterine cramps, kind of like cramping that a woman would experience with her menses. And so after pains are contractions of those uterine fibers or uterine muscles. And what we see is oftentimes the molar multiparous or the molar gravid the woman is, the increasing in the intensity of after pains. We also see after pains increasing with breastfeeding or with uterine overdistension. So having her, if she has a very large for gestation baby or a macrosomic baby where the uterus is really big and stretched out, we can see an increased incidence of after pains. After pains are an important part of the healing process, and it helps return that uterus back to the normal state. It usually lasts around 6 weeks, but should become less and less. It is encouraged to use ibuprofen prior to breastfeeding to help decrease the pain in those women that have severe after pains. With the uterine lining, as that placental site heals, really it's when the placenta comes off of the uterus, it's called sloughing. And so as that placental site heals, that's what our lochia should kind of be cognizant or kind of reminiscent of. So the lochia is then the uterine charge after childbirth, so it's much like a menses. So it starts usually as a bright red, and we call that rubra. Sometimes there can be small spots. It's just typically heavier than a normal period. And then it will steadily decrease over time. So when we're getting into days 2 and 3, that lochia might be lochia serosa, so maybe a pinkish, or it could have some brown tinge to it. And that lochia can last 22 to 27 days. If the woman is seeing the decrease of lochia, if she would return to heavy bright red bleeding or have foul smelling odor or be saturating more than 1 pad an hour for 2 consecutive hours, she does need to have reevaluation, because it might be that she has a retained placental part or some type of infection. So just different things to think about. Also, upon return home after childbearing, it is important to let her know that if her flow does start increasing, it's important for her to rest. So laying down, increasing some fluid intake, and then watching her flow to see what that is like. So as I said, the rubra is usually the first 3 days. It's consistent with blood, decidual, and trophoblastic debris. The lochia serosa can last up to that 27 days, and the lochia serosa is really old blood, so that's where that kind of brownish, dark red, serous type drainage comes into play, and it's from that, as well as serum, leukocytes, and tissue debris that are all part of that healing placental site. And then the lochia alba is really just kind of a light or maybe very pale pink in color, and that consists of mainly leukocytes. The woman that has a C-section will probably not have as much vaginal flow as the woman that has a vaginal delivery, because after the C-sections we typically see your surgeon wiping out the inside of the uterus. So when we're talking lochia amounts, you do need to be cognizant of amounts. So when you're talking about amounts, always remember to look at the chucks beneath her bottom as well, in case the flow tends to go with the nature of gravity and flow to the back. If she is wearing an ice pack, be looking at the ice pad and what is noted on that as well. I'm going to click to the next picture and then talk about the amounts. So when we talk about scant, that would be the top one. So it's a 2-inch stain or less. Light being around a 4-inch stain, moderate 6-inch stain, and then large is typically saturating that pad, maybe soaking onto the chucks behind her. So in order to prevent postpartum hemorrhage, it's very important to maintain uterine tone with the massage, expelling clots, preventing hemorrhage. Explain to her that yes, it can be painful, but it's very important. It's a good idea to teach her how to palpate her fundus as well in between times. So lots of different things to be thinking about. Also, we will be looking at a postpartum hemoglobin and hematocrit. And we want to make sure that we do keep an accurate pad count. So every time you change a vaginal pad, you should be documenting that into the electronic health record. And so we want to be cognizant of our pad count and the amount of time that lapses between changing the pad. And obviously during those first 4 hours, we're going to be changing it more frequently, and that's okay. But we do want to see that decreasing gradually over time. When we're talking about the abdomen in the postpartum period, immediately after birth, sometimes women's abdomens protrude a little bit, and that is due to the diastasis of the recti abdominis, which is that muscle on the anterior portion of the abdomen. Those muscles will return normal tone or close to pre-pregnancy tone with proper exercise, and if she doesn't have a lot of adipose tissue, so weight loss, those types of things. Striae or stretch marks are very common, and those will persist after delivery. They will, however, lessen in color and size. And usually it takes around 6 weeks for the abdomen to return to the normal pre-pregnant state. So it's important to tell women not to bring their pre-pregnant clothes with them to the hospital, because they're probably not going to fit into them when they go home. With urinary elimination, we do see kidney function returning to normal, typically around a month after birth. What we do see is if you have a woman that has severe edema or swelling, things like that, what we'll see is that diuresis usually begins around 12 hours after delivery. So we do want to encourage our moms to get up, urinate frequently. And so with frequent urination, that's going to help keep her uterus firm, keep that fundus firm. It's going to decrease hemorrhage risks. And then it also decreases rates of infection, so she's not, sitting in the same vaginal pad for prolonged periods of time. If she does have a C-section, we're going to leave that urinary catheter in place for about 24 hours until full sensation returns, and then hopefully once we remove that, she'll be able to void independently. Pelvic soreness, episiotomy lacerations, using a spray bottle while she urinates will be very beneficial during the postpartum period. And so while she uses the restroom, it's very good to have her kind of spray her bottom, and then when she's getting ready to wipe, just sort of pat dry. With nutrition and elimination, oftentimes moms are really hungry after delivery, but we want to encourage her to kind of start low and light, because oftentimes with the changing hormones and the excitement, things like that, she might become nauseated, and we wouldn't like her to vomit full-fledged food. So kind of starting low and then gradually building upon that, using frequent snacks, those kinds of things. Bowel movements, usually about day 2 to 3 is when we're going to be seeing bowel movements occur. If you have a mom that's using pain medication, such as your C-section mom, it's kind of a good idea to follow up with her providers, see if we need any stool softeners ordered to prevent constipation, because we certainly don't want her to be constipated, especially in our moms that maybe have 3rd and 4th degree lacerations or extended episiotomies. Definitely don't want them constipated. So high fiber foods, adequate fluid volume, those types of things are going to be really important. Usually it takes about a month or so for regular bowel patterns to return, but just remind her, rest assured, it will occur with time. I'm going to stop here, and then I will continue on, starting with talking about breasts and breastfeeding and those types of things on our next voiceover. Thanks for your attention.